So should I start, sir? Bajwa, sir?
Please.
Yeah. Good evening, everyone. Respected Chairperson, faculties for today, and IISc national dignitaries. Our Honorary Secretary Dr. Supinderji Singh Bajwa, sir. My co-program heads, Dr. Chintala Kishan and Dr. Manoj Kumar, sir, and all the delegates who have joined for this ISA CRISP 3 series, that is Clinical Reasoning and Problem Solving interactive webinars. And today we'll be discussing mainly geriatric anesthesia and effect of different inhalational as well as intravenous agents, the drugs which are using in day-to-day anesthesia practice, and their effects on the aged heart. Well, this topic why I chose because many of the times we have doubt in our mind what to use for induction of anesthesia in aged heart, whether to use propofol or etoposide. I am practicing in interiors of India. I have only halothane available with me. Should I use that halothane or should I ask for some newer inhalational agents? So these kinds of questions are always there in the minds of many anesthesiologists who are practicing all over India. So let's discuss this topic in detail with all the dignitaries who have joined for this webinar as chairpersons and faculties. I invite our Honorary Secretary, ISA National, for his introductory remarks.
Thank you, Dr. Manisha. The main purpose of starting these type of webinars have already been explained by Dr. Manisha. The idea behind it is that during the conferences or the CMEs where we are meeting physically or asking the questions directly, many times, sometimes we feel little shy to ask the direct question to the speaker. We always feel that little bit embarrassed that my question may look silly or stupid or low standard, that if I ask this question, I may become a laughing stock. So many times what we do when we attend these conferences or CMEs, we feel little shy to clear our doubts there. And moreover, it's very difficult to attend to all the CMEs and conferences because there will be logistic problems, the vacation, the holidays and offs and practice. And for the practitioners, very difficult to leave the practice and go to attend these conferences, because just for attending a lecture there, it doesn't give them a much incentive to stick to these academic programs. The idea of starting the CRISP and CLIP is there are two different platforms on where we can, not just the practitioners, but other anesthesiologists also. Just like few years earlier, I was also like that. I was not able to, ask the questions. Suppose Dr. Gopinath sir is giving a lecture. If I ask him about anything cardiac anesthesia, so I would be feeling embarrassed. So if he says something, then I will become, feel shy in front of everyone, or I will feel embarrassed. So that's the idea. Here, what people do, they keep asking the question in the chat box. When the discussion is going on, and we have got eminent faculty. It's not just a one person or two person. We have got almost 8 or 9 people here. Anybody can answer. All the doubts can be cleared. A decision can be made, and which can be helpful for the practitioners, the academicians, as well as the students. So this is a platform where we really provide them a good discussion scenario where they can clear doubts. Sometimes, somebody logging with an iPhone will write iPhone M13, something like that, so that their name is not identified, but they can write the questions. At least we have a duty to answer those questions also. But at the same time, identity is not revealed, but the doubts can get clear. So this is the highlight of this CRISP and CLIP, and it's doing wonderful. And these are the program of ISA, as I told in the group in the morning, the ISA program like PG classes, CRISP, CLIP, and ISA IJ webinar. These are our national priority things, and we will be giving our full impetus to these programs. And with that, I think I will not be able to explain much more than that. I hand over the mic to Dr. Manisha so that we can kickstart today's program. Yeah. Dr. Manisha, please.
Thank you so much, sir. I welcome our Honorary Treasurer, ISA National, Dr. Manoj Kumar. Sir, your introductory remarks, please.
Thank you, Manisha, madam. As a program head, I would like to welcome our Honorary Secretary, ISA National, our co-program head partner, Dr. Chintala Kishan, sir, and Dr. Manisha, madam, and today's chairperson, for the geriatric anesthesia, Dr. R. Gopinath sir and Dr. Thomas Kossi sir. And the speakers, today's speaker, Dr. Gurikwal Singh, Dr. Balaji sir, and Dr. Hetal sir. I welcome all of you, sir. And today academic moderator, Dr. Sujata ji and Dr. Neeru Shani. I welcome all of you, madam, and all delegates and all the IC members and all the PG students. Welcome all you and thank you very much, ISNS now.
Thank you, sir. Dr. Chintala, sir.
Good evening, everybody. Respected IAS National Secretary, Dr. Sukhminder Singh Bajwa sir, and Treasurer Manoj Bhai, and my colleagues Manisha Madam. Thank you very much, Madam. This is a very good program. I welcome Dr. Gopinath sir, Koshi sir, and all other seniors for this wonderful program. Today I am waiting for eagerly to hear this very good programs. Thank you very much.
Thank you so much, sir. We'll start with the program now. Today we have very enthusiastic and dynamic young academic moderators with us, Dr. Sujata Jine and Dr. Neeru Sahani. Let me introduce them. Dr. Sujata Jine is consultant anesthesiologist and in practicing in Ozone Anesthesia Group, the famous anesthesia group in Aurangabad ISA. She is practicing for 13 years with areas of interest in regional anesthesia, obstetric anesthesia, difficult airway, pediatric anesthesia. We have seen her enthusiasm in many ISA activities. She is honorary secretary of ISA Aurangabad at the moment. She was organizing secretary for ISA National Sponsored CME 2022 and received State Appreciation Award for Best Clinic as well as the highest Diligent Award of 2022 of ISA National. Dr. Neeru Sahani, she is Associate Professor working in Department of Anesthesia and Intensive Care, Postgraduate Institute of Medical Education and Research, and is having 15 years of post-MD experience. She has 55 publications with 265 citations, and critical care, sepsis management, quality indicators in ICU are her areas of interest. Welcome both the academic moderators, Sujata and Neeru. I request Dr. Sujata to start the program.
Thank you, Dr. Katikar, madam. You made my job very easy. A very good evening to everyone and a warm greetings from ISA National Digital Platform. I take the privilege to welcome you all for the Series 3 of ISA CRIPS session, which is on geriatric anesthesia. Before we start, I welcome all the office bearers of ISA National, all our speakers, chairperson, and program heads for this interactive clinical reasoning and problem-solving session. As said by Albert Einstein, education is not learning of fact, but rather it is the training of mind to think. Let us begin the session. And as we have all the expertise for today's session, I request everyone to be very active during interactive session and train our mind to deal with the case-based problem. It's an honor to have respected Dr. R. Gopinath sir as a chairperson for today's session. May I request Katikar ma'am to share the CV of sir? Sir is a professor and head of Department of Anesthesia, ESIC, Medical College and Hospital, Hyderabad. Sir has professional experience of more than 40 years with a special area of interest in cardiac anesthesia, pain relief, research and interactive sessions. Sir is the medalist as well as a member of editorial board of various journals and an examiner and an inspector. Sir has more than 140 index publications, delivered more than 200 lectures, contributed for more than 6 chapters, and on the top of all, Sir has delivered 6 orations. Sir has organized various national and international conferences and many workshops. I welcome you, sir, and please accept the digital gesture and a warm welcome. Dr. Neeru.
Good evening, everyone. So our next chairperson is Dr. Thomas Kossi. It's my privilege to introduce Sir. Sir is a very senior anesthesiologist. He is senior professor in cardiac anesthesia and working in Sri Chitra Thirunal Institute of Medical Sciences and Technology, Trivandrum. Sir has contributed to scientific literature with his numerous publications, research projects. He has given about 200 lectures, conducted various workshops, and given 5 orations. Sir is currently holding Senior Vice President post in IACTA, and he has held prestigious posts in all the societies previously in the Indian College of Cardiac Anesthesia, IACTA National Treasurer, and ISA Kerala State Branch. Sir is also Fellow of Royal College of Physicians, Edinburgh. We welcome you, sir, to today's crisp session.
Now I welcome the young and dashing speaker, Dr. Gurigbal Singh. Sir is Assistant Professor in Cardiac Anesthesia, UN Mehta Institute of Cardiology and Research Center, Ahmedabad. With 4 years experience of cardiac anesthesia, Sir has more than 16 publications to his credit. Sir is also a gold medalist and holds first rank in MD exam. With this very strong academic profile, I welcome you, sir, on ISA National Digital Platform.
I would like to introduce our next speaker, Dr. Balaji, sir. He is the director of Ozone Anesthesia Group, currently working in Aurangabad, and he's also president of Snehaswali Geriatric and Palliative Care Center. We welcome you, sir. He has a lot of research publications. He's given a lot of talks in CMEs and conferences, and he is the author of Handbook on Practical Approach to ABG Analysis. He has been ex-secretary Maharashtra State ISA branch. He has received Proficiency Award by National ISA twice. He has also received the Diligent Award in 2022. And considering that he has received Appreciation Award by Geriatric Society of India, we feel privileged to invite you, sir, for today's session on geriatric anesthesia.
Now I welcome Dr. Hetal Shah, sir. Sir is a senior consultant cardiac intensivist and a clinical lead working at Ahmedabad. Sir is a renowned faculty at ISA, IACTA, IAPA, and ISA. Sir, with his professional experience of more than 20 years, sir has many publications and awards to his account. With the award-winning faculty, with few to name to his account, our best paper publication, West Zone, Dr. KOPS Award by ISA in 2021, the most prestigious one, Chairman Award for Best Doctor in the group. Sir presently holds the post of Honorary Secretary of ISA Ahmedabad City Branch. I welcome you, sir, and nice to see you after Mahayuvacon Nasik.
Thank you.
Now I know everybody are eagerly waiting to listen to the dashing speaker on his experience on post-induction hypotension. Over to you, Dr. Gurigbal Singh, sir.
Unmute yourself, Dr. Gurigbal. Please unmute yourself. Share your screen, please.
Yeah.
Okay.
So, good evening, everyone. I'm presenting how I do it, post-induction hypotension. So what is post-induction hypotension? It is a hypotension which occurs within first 20 minutes following anesthesia induction, or from anesthesia induction till the beginning of surgical incision, when the blood pressure, systolic blood pressure fall to less than 90 or mean arterial pressure decrease more than 30% in comparison to the baseline, that constitute the post-induction hypotension. Now, there are various articles and systematic reviews published which say that older age is independently associated with post-induction hypotension. So now why elderly are more prone to post-induction hypotension? They have decrease in age-related decrease in stroke volume and cardiac output. They have subnormal cardiac responsiveness to the stress. There is a decrease beta receptor responsiveness and more preload dependence. There is a increased incidence of arrhythmias because of fibrosis of conduction system. because of increased afterload and myocardial fibrosis, they have increased incidence of LVH and more dependence on the LA contraction for the LV filling. So normal sinus rhythm is very important. They have decreased baroreceptor sensitivity and other comorbidities like coronary artery disease, AS, and diabetes. So all the anesthesia drugs, they are they cause more hypotension in these patients because of the profile. They have less total body water and lean body mass and high fat, which can lead to high peak concentration of the anesthetic drugs, and there is a decreased dose requirement. And also because of increased total body fat, they are prone to the prolonged duration of effects of these agents. There's a reduced renal and hepatic metabolism. So there's a delayed induction of anesthesia following administration of IV anesthetic agents due to reduced cardiac output, and inhalational induction would be faster. So high concentration of inhaled anesthetic can also cause exaggerated effects. And so it is smart to start low and go slow while administering these medications. Other than age, there are various risk factors. If those are present, we can anticipate post-induction hypotension, like higher ASA grade. If the baseline mean arterial pressure is less than 70, or the patients are taking ACE inhibitors and ARBs, if there's an emergency surgery, and if we are using propofol for induction of anesthesia, or we are doing using higher dosage of fentanyl. Now, how we prevent and manage post-induction hypotension? Starting with the pre-op examination, we need to assess the functional status, get a baseline ECG done, lab investigation like hemoglobin and hematocrit, and we can do the cardiac testing in a patient who are undergoing intermediate or high-risk surgery with less than 4 METs activity and with more than three risk factors for coronary artery disease. We also need to rule out certain diseases like unstable coronary syndrome or decompensated heart failure, any significant arrhythmias, and critical valvular disease. Now, how we optimize the medications, if the patients are on beta blocker, ACE inhibitors, diuretics, they are more prone to develop post-induction hypotension. While ACC/AH guidelines recommend that those who are chronically treated with beta blocker, we should continue this therapy. While there is a lot of controversy surrounding use of ACE inhibitors and ARB, though the ACC/AHA guidelines recommend that continuation perioperatively is reasonable for patient undergoing non-cardiac surgery, although there is a potential risks and benefits are limited to only observational studies. So there is this one article published in Anesthesia and Analgesia which address this issue, that whether to stop or not. So they are saying that to continue these drugs in patients who are taking them for management of hypertension, and on the other hand, it is reasonable to withhold them on the morning of surgery in patients who are taking them for congestive heart failure and in whom the baseline blood pressure is low, to avoid the post-induction hypotension. Diuretics, it could be continued if taken for control of blood pressure and can be discontinued otherwise on the day of surgery. So we must optimize the preoperative fluid status to prevent the post-induction hypotension. So avoiding prolonged NBM hours and encouraging clear fluid up to 2 hours before induction of anesthesia, as recommended by recent ASA fasting practice guidelines. And there are recent studies which demonstrate utility of pre-op IVC collapsibility index, which can predict fluid responsiveness, which is it's a non-invasive modality and could be done where we are not going for any invasive monitoring, especially in the non-cardiac surgery. So we in the pre-operative area, we can just do with the subcostal view with the echocardiography probe, we can get the IVC diameter maximum and minimum and get the collapsibility index. If the cutoff value is around 50%, if it is more than that, that means patient would be fluid responsive. Now, when we are going for induction of general anesthesia, we will apply standard ASA monitor. And if there's a high risk surgery and a lot of fluid shift is recommended, we can go for invasive monitoring of arterial pressure and central venous pressure. Better to go for 2 large bore IV cannulas. We need to, as discussed, they are more prone to the hypotensive effects of anesthetic agents. So titrated and reduced induction dosages of propofol and etomidate is known to cause less incidence of post-induction hypotension. So it's preferable. We can reduce the dosages of benzodiazepine like midazolam. Rapid IV dosing at short interval and high concentration of volatile anesthetics should be avoided. Propofol opioid combination is known to cause less hypotension as compared to benzodiazepine opioid combination. Vecuronium, though it is a cardiostable drug, but it can cause negative chronotropic and inotropic effect, especially the patients who are having this polypharmacy. They might be on beta blockers, CCB, ACE inhibitors. And when we are going for subarachnoid block or epidural block, lesser dosages of local anesthetics. Now, how do we manage the post-induction hypotension? So first, we need to assess the fluid status, optimizing preoperative fluid status, and when the hypotension develop, we can go with the fluid boluses in the increments of 5 ml per kg or 250 ml. Temporarily, we can go for Trendelenburg position. So if the patient is not responding to the fluids, we can go for the vasopressors. They are administered to treat hypotension, which does not immediately respond to fluid boluses or decreasing the anesthetic depth. We can go for ephedrine, especially in the patient who are having bradycardia along with the hypotension. We can administer in the boluses of 5 to 10 mg, but it also causes tachyphylaxis. So maximum we can go up to 50. Then phenylephrine, if the patient is having normal or elevated heart rate with the hypotension, we can go for the bolus doses of phenylephrine of 50 to 100 microgram or as a continuous infusion of 10 to 100 microgram per minute. So if it is not responding to these bolus dose of vasopressor, we can go for norepinephrine in the dosages of 0.01 to 0.1 microgram per kg per minute infusion, or a bolus dose of 4 to 8 microgram. So if the patient is having non-cardiac surgery and we don't have central line, it can be given via titrated infusion via large bore peripheral IV catheter. Now, vasopressor, it has a limited role if there is no component of sepsis there, but it is often added as a supplementary agent to treat hypotension after inadequate response to other vasopressor, and especially in the treatment of hypotension refractory to the administration of catecholamine or sympathomimetic. For example, if the patient develop vasoplagia due to chronic administration of ACE inhibitors, we can use it in a dosage of 0.01 to 0.04 units per minute. Epinephrine administration is typically reserved for the treatment of anaphylaxis or cardiac arrest. And after giving the fluid, optimizing fluid, giving vasopressors, and still the patient is not responding, we need to rule out the other causes, maybe anaphylaxis, or if it might be due to airway related issues, pneumothorax, or pulmonary embolism, or unrecognized clinical entities like aortic stenosis or HOCM, or there also could be the adrenal insufficiency. These are my references. Thank you.
Thank you, Dr. Gurigbal. I think you have summarized most of the problems encountered post-induction following general anesthesia. So, very important factors you have stressed upon is that preoperatively they should be optimized, at least for fluid status.
Yes.
Geriatric patient, most of them, we encounter in the emergencies, especially fractures. So the commonest, of course, is to use a regional anesthetic technique, but again, GA in some patients would be valid. The problem again in the elderly is that they're very reluctant to partake in fluids because they need to use the washroom, or they feel uncomfortable to ask for help. So it is very important that you have to ensure that volume status is maintained. Not all would probably do an ultrasound at the time of, to assess IVC diameter. So I think one of the simplest things is, functional hemodynamic with leg elevation to see if we can respond to volume. So that would be a good way of doing it. Trendelenburg, yes, but quickest would be this. And if they do jack up their pressures by 10 millimeters by leg elevation, yes, give them a fluid bolus. And if it still doesn't respond, yeah, you have given us the various options. About ACE inhibitors and ARBs, practically, personally, yes, I would discontinue them, because you must understand that anybody beyond 50 has diastolic dysfunction.
Yeah.
And these are the patients, though it's not a fibrosis that is, myocardial fibrosis is not present in all, but they do have, they are very dependent on, LA systole. So I think it's prudent to not give them in the morning, though there are no definite guidelines. So if they are only on single dose or single or therapy with ARBs or AC inhibitors, we can always add a calcium channel blocker or a small dose of beta blocker on the morning of surgery for better control. So apart from that, of course, yes, choice of drugs. So not in an emergency, not everybody would keep epinephrine, phenylephrine, norepinephrine, vasopressin available. So most elderly would, have lower heart rate. So I think ephedrine would be the first choice always. So apart from that, a well-preserved elderly patient should not generally give you a lot of trouble. But again, we understand that several circulatory beds in various organs like CNS, kidney, all would definitely, even with one single episode of hypotension, would have consequences in the post-op, POCDs or AKI. So it's very, very important that you avoid hypotension or treat it at the earliest. So that should be the take-home message in these patients. So the generally recommended sort of cutoff would be 70 to 80 at least, because if they are hypertensive, there is a rightward shift of autoregulation. Even if they are controlled hypertensive, it makes them worse. And these beds suffer the most. So I think in those terms, pre-op evaluation, optimization, be very wary that these are the patients who are almost always likely to have a brief spell of hypotension, especially following GA, maybe more so if they've got a needle in the back for a regional. So thank you, Gurigbal. I think that was a very concise presentation. Thanks.
Thank you, sir.
I request Dr. Koshi sir also to please give his expert opinion on Dr. Gurikbal's talk and on this topic of geriatric anesthesia.
Yeah, Singers covered the topic very well, especially the treatment part. So before commenting further, Gobi has nicely covered the expert opinion. But why are we, my question is, what is hypotension? How much duration is considered as significant? And why are we worried about hypotension? So whether it is a mean arterial pressure of less than 65 or less than 70 or less than 60, what's the duration? Whether it is less than 15 minutes, more than 15 minutes. And what are the adverse, if there is less than 15 minutes or more than 15 minutes, what are the adverse events? Whether it will affect, it will produce an increase in 30-day mortality rate, or MACE, major adverse cardiac event, or increase instance of delirium, or a increase in kidney injury. Now, how you manage fluid status, whether it is a goal-directed fluid management in elderly people, or the way we manage routinely give fluid. So these are the things to be addressed on, and how we check into this. We look at the literature. We look at the literature and what are the evidence for this. So recently about this topic, there is a series of good articles that come out in major journals, including Anesthesia and Anesthesia. And these studies have been started in multiple centers, lakhs of patients. So I'll quote the one study which has come in Anesthesia and Anesthesia in 2021. So it's very recent. So intraoperative hypertension is associated with adverse clinical outcome after non-cardiac surgery. So this is a study conducted in 3.5 lakhs patients from 2008 to 2017, adult patients, all age group. And so they studied the hypotension less than 55, less than 60, less than 75, less than 80. And what they found that intraoperative hypertension during non-cardiac surgery is common and associated with an increased 30-day major adverse cardiac or cerebrovascular events. And observation is magnified with increasing hypertension severity. So they recommend prompt management of hypertension, whether it is immediately after induction or during surgery. So that is a major study. Now, what are the complications of hypertension? That's already I mentioned. One is major adverse cardiac event. Second is cerebrovascular event. Third is a delirium. And fourth is a kidney injury. Now, so there was a study. They had a hypotension preventing anesthesia and hypertension preventing anesthesia. So hypertension preventing anesthesia, they kept a lowest blood pressure is around 60 mean arterial pressure. And the hypotension preventing anesthesia at mean arterial pressure of 80. So that is again is a large study across multiple centers. That's also come out in a major journal. And they found that there is no difference between a 60 mean arterial pressure and 80 mean arterial pressure. But the odds ratio between the two groups for major adverse cardiac events, kidney injury, and cerebrovascular incident is same. Now we are dealt with another study. How much duration? Less than 15 minutes or more than 15 minutes hypotension. So one study has found that even a 1 minute hypotension can have a adverse kidney thing. So one thing from the studies, it's clear that hypertension has to be promptly managed. How you induce, Dr. Singh has clearly mentioned, you have to give less dose. You have to, all age people are susceptible to the hypotensive effect. So instead of 4 milligram, 5 milligram, give 1 milligram. Propofol instead of 2 milligram per kg, you go to the 1 milligram and increase the dosage interval. And the third is fluid management. Fluid management, you can go by either dynamic variables like pressure, pulse pressure variation, systolic pressure variation, which is available in the monitor. That is the gold director or conventional. So if you are going for a geriatric patient, going for a intermediate high-risk surgery, better to use is one of this gold director therapy, like systolic pulse pressure variation. You switch it on the modern, most modern ventilators have got pulse pressure variation there. Switch it on and manage like that. Otherwise, it's a short duration surgery, not much. You see, our conventional way of giving 3 ml per kg non-sensible loss and give smaller dose and increase the dosage interval, and you can get away with hypertension. If hypertension occurs, promptly manage it. This is a update on this topic currently. Thank you. We covered the topic. Management is very well. You have to use vasopressin. You have to use noradrenaline. But again, there is a controversy. You go for a restrictive fluid regimen with vasopressor or a higher fluid management without vasopressors. Anyway, there is no consensus. Both ways you can use. So whatever is convenient with you, you use. You go for restricted fluid with vasopressors or give more fluid and lesser vasopressors. So that is my what you call opinion regarding this particular topic. Thank you.
Thank you, sir. Thank you, Dr. Gurikpal. We'll be proceeding to the second session. Dr. Sujata. Dr. Sujata, please unmute yourself.
Yeah. Our next session is crackling the scientific dilemma. I'll be sharing the screen. Just a second. Share now. Yeah. Just to initiate the discussion related to our topic, I would like to take here the two cases. The first one is a 94-year-old male patient, moderate build male, posted for bilateral laparoscopic inguinal hernia. He is known case of ischemic heart disease, hypertension, diabetes mellitus, hypothyroidism, and with Parkinson's disease. Patient is on regular treatment and follow-up with all systemic diseases. Currently, patient is on following medications like telmisartan 40 mg OD, tablet alpha-methyl dopa 250 mg BD, ecosprin 75 mg OD, which has been stopped 5 days prior to the surgery, tablet metformin 500 mg BD, and tablet thyronorm 50 mics OD. His effort tolerance is less than 4 med score, able to move around in house and do all the self-care activities. On examination, airway patient is edentulous with a MPC grading of 2, limited neck extension, vitals were stable with a borderline blood pressure. Investigation, all blood investigations were within normal limit, except serum potassium, which was 3.2 milliequiliters. And the thyroid function was within normal limit, HbA1c was 6.4. ECG suggestive of IHD changes, 2D echo was suggestive of EF of 45%, mild LV systolic dysfunction, mild MR, TR, and mild pulmonary arterial hypertension. And the case 2 goes like 67 years old male patient who is known in case of CA ascending colon, who is posted for right hemicolectomy. 4 years back, patient had an history of chest pain, and there was he underwent angioplasty with a PTCA to LAD and LCX. Patient does not have any other comorbidity. He was a reformed smoker for last 3 years. Effort tolerance was more than 4 meds. On examination, moderate build patient with good airway, vitals stable, and ECG normal, with echo suggestive of regional wall motion abnormality, LA apical hypokinesia with EF of 30%, with LV clot and diastolic dysfunction grade 1. So how do we proceed with such case? So before we discuss the case scenario, we would like to listen to the experience of our next speaker. Dr. Neeru, please, can you highlight?
I invite Dr. Balaji to please highlight us how he handles these kind of dilemmas, the post-induction hypotension and the management of this hypotension, and how to maintain the anesthesia in these sick elderly patients. Dr. Balaji, please.
Madam, good evening. First, should I do my presentation?
Yes, sir. So the presentation only.
Okay. Yes. Good evening, everyone. And I'm really thankful to ISA National for such a wonderful academic initiative, especially Dr. Bajwa sir, Katikar madam. And these sorts of efforts are really helpful to those anesthesiologists who are working in periphery. Today, I'm going to talk on a very precise topic, that is, inhalational anesthesia challenges in aged heart. With the permission of respected chairpersons, I will start. Now, Dr. Gurikpal Singh has made my job little bit easy, because he already talked about what are the changes occurs in geriatric patients as far as heart is concerned. There are anatomical as well as functional changes. There is decreased elasticity, as he rightly told. There is reduced beta response. There is reduced low compliance, and ultimately it leads to a decreased cardiac output and heart rate. If you see towards the heart, there is hypertrophy occurring. There is ischemic changes might be there. There are fibrosis occurring, and ultimately all what is it clinically it is leading to increase afterload and decrease coronary perfusion pressure, coronary perfusion, which is a perfect synergy to patient to go in ischemia, and there occurs hypertrophy and fibrosis. As far as vascularity is concerned, there is decreased elasticity, hardening of the arteries occurring, which is leading to increased systolic blood pressure and decreasing diastolic pulse pressure. And ultimately, this all leads to patient has got less tachycardic response to a hypotension if at all it occurs. There is a very labile blood pressure that's occurring patient. Most of these patients, particularly geriatric patients above 75 U80, they can have a coronary artery disease. Diastolic dysfunction is diastolic heart failure is very, very common. And in this diastolic heart, normal systolic heart function is normal, but patient has got a diastolic dysfunction. That is why patients are very intolerant to the fluids, and they can land into a failure. Then due to degenerative changes, they are occurring conducting abnormalities, which is making bradyarrhythmias very common. At the same time, atrial fibrillation is also common due to increase in the size of left atrium. So overall, geriatric heart is a very perfect scenario for complications. Another important term that probably I want to talk is frailty. What is frailty is age-related deficit in normal function involving several body systems. Patient may have clinically more or less a good heart of system, but once patient is become frail, he is very weak. He has got a very slow activities, and it is all, it may be due to aging, lifestyle, or age related, but there are chronic inflammation process that is going on in the body, and that is leading to weakness, weight loss, exhaustion, muscle loss, what we call it as a sarcopenia, means active loss of muscles, and ultimately it leads to increased chances of surgical risk, increased chances of morbidity, decreased chances of post-op recovery, decreased chances of rehabilitation. This is very, very common in a frail person. There was a very interesting study about frailty in cardiac surgery. More than 66,000 patients have they have studied, and what they find that in frail patients, patients have almost double the chances of mortality, almost triple the chances of mortality, double the chances of morbidity. There are high chances of sternal dehiscence, and they are less likely to have a discharge as compared to those patients who are not frail. So as far as effects of inhalational agents, what my topic want me to speak, what's happening in normal individual also, when you give inhalational agent, there is decreased mean arterial pressure as the dose of anesthetic agent is increasing. Our sevoflurane, isoflurane, desflurane, they causes a reflex tachycardia when mean arterial pressure is decreased, especially more with the isoflurane. And even they can prolong the QT interval, which can initiate the various kinds of arrhythmia. As far as sevoflurane, it has got a less pronounced cardiovascular effect. As far as isoflurane is concerned, it can cause a coronary steal. What do you mean by coronary steal? Suppose there is a coronary artery disease in one vessel and normal coronaries in other vessel. Due to active coronary dilatation by the isoflurane, blood flow to the normal vessel increases and ischemic vessel decreases, which can increase the ischemia. I have not deliberately taken halothane because halothane is itself, it decreases the mean arterial pressure. It itself is a myocardial depressant. Apart from that, it can sensitize the myocardium for the effects of catecholamines. It itself have maximum hepatic metabolism. And nowadays, for all geriatric patients or very high-risk patients, halothane is not at all recommended. Now, inhalational agents, when you want to use it in geriatric, there is a 30% decrease in the requirement in MAC as compared to the young adult. Or as age advances, every decade, the 6% decrease in the minimum alveolar concentration of the drug that is required for anesthetizing the patient. Why this is happening? Because there is a reduced brain volume, there is active loss of gray matter, and even the fluid is increased in the blood active. That is why the requirement of anesthetic agent is less. And how this inhalational agent go to the brain, through the lungs, to the blood, and through any problem with the lung or blood or a brain, naturally there will be a problem or there will be a compounding effect while the using inhalational agents. Now, there are two important aspects that always ask about what whether inhalational agent produces a ischemic preconditioning. What is ischemic preconditioning? It is preparing your body or heart to undergo stress before actual stress conditions occurs. And it is proven in many studies that in many meta-analysis that these inhalational agents gives the can cause ischemic preconditioning. This is a meta-analysis of more than 15 studies. This is a 2015 paper, and they say that sevoflurane exhibit a more favorable cardioprotective effect during cardiac surgery than a propofol. As far as, again, in this study of cardiac protection with halogenated agent, they said that there is greater cardioprotection when you use inhalational agent for maintenance of anesthesia during the surgery. How they calculated it? By calculating the post-op levels of troponin and BNP levels in post-op patients. Another study which suggests comparison of volatile anions induced in preconditioning in cardiac and cerebral system. What it is again a bit recent 2018 paper. Again, they say that extensive evidence of animal studies, the volatile anesthetics have beneficial effect to protect the myocytes and neuron from ischemia and reperfusion agent. Another most concern in post-op period is post-operative cognitive function, and it is said that inhalational agents can cause post-op cognitive dysfunction, and which is really a major problem when you actually deal with these patients in a post-operative period. So what literature says that in intravenous versus inhalational maintenance of anesthesia post-operative cognitive outcome elderly undergoing non-cardiac surgery, and 28 RCTs, they have found a low certainty of evidence that inhalational agents will cause post-operative cognitive dysfunction. Even in one study that almost 2018 RCT compared with GA and spinal anesthesia on occurrence of post-operative cognitive dysfunction in post-operative up to 30 days, but they find that choice of anesthesia modality did not appear to influence on the emergence of post-operative post-cognitive dysfunction in elderly patient. Now, whenever we are anesthetizing perioperative, our objective is to maintain stable hemodynamics, as Dr. Koshi rightly told. We want a minimum physiological alteration. These aims are very difficult to manage, but these are our aims. We want goal-directed therapy so that there should not be overload. At the same time, patients, many times, they are underfilled. So many old age patients, we see their intake is such a minimum. Most of the times they are taking very small, less water intake because they want to avoid to go to for urination, and they are many times they are dehydrated. So what is first previous speaker has told, hypotension is very, very common, and the most commonest cause for this is lesser fluid. Then avoid too much of polypharmacy, which can invite so much of trouble. So as far as anesthesia part is concerned, titrate all the drugs. Never give boluses, just use drugs very slow. This is our aim. And we want, at the same time, recovery should also be very fast. We routinely practice intravenous induction with drugs like intermediate, which are relatively cardiostable, or we give sedation, we wait for 5 to 10 minutes, then induce the patient with lesser dosage of propofol. Then maintenance of inhalational agent. As age increases, we reduce the maintenance dose of inhalational agents. We ventilate the patient with low tidal volume and follow the lung recruitment measures because we don't want a post-op atelectasis. We try to avoid hypotension. It may not be possible, but it should be promptly detected, but promptly treated also. Nowadays, so many good inotropes, vasopressors are available, and we should ready with all these syringes and all these drugs so that we should avoid hypotension. Another important thing is we must avoid hypothermia, which is very, very common due to air conditioning system in OT. Hypothermia is very common in these patients and we must avoid. In all this geriatric age group, 90 or 95 years, less is more. Try to give minimum drugs, try to give, titrate the drugs. That is very, very important. Always use multimodal analgesia, combine regional anesthesia with GA, so that your requirement of anesthetic drug will also reduce. At the same time, you will get a profound analgesia. Most of the time, analgesia is neglected part, particularly in pediatric patient and in geriatric patient. But adequate analgesia is very, very important. It itself can decrease the incidence of post-operative cognitive dysfunction. And early ambulation and feeding is our target. So in geriatric patient, there is on one side reduced physiological reserve, and other side they have very less ability to respond to a period of instability. It's very difficult, or it's very challenging to manage geriatric patient. It's like a tight rope walk on the rope. So these are the very challenging cases. So geriatric patients are very delicate and fragile. Only things that we can do is handle them with optimum care. Thank you and wish you a very happy monsoon season.
Very nicely covered, Dr. Balaji, because I was hoping you would bring up the topic of frailty. Just very important to understand. If you have an elective surgical patient who's in the elderly category, yes, so much you can do to optimize and counter the effects of frailty. But in, say, time urgent like oncological surgeries or fractures or other things which can have to be taken up quickly, you need to be very, very sure that you have got a patient who can be will tolerate all these that you put at him. So volatile induction, volatile agents per se in the elderly, yes, are associated with some amount of cardioprotection or organ protection at multiple organs. Also, yes, if you use higher MAC, you have a problem. So I would advise people to use some form of neurological monitoring, especially BIS, to help you to keep these patients not too sedated. The other, of course, basically is that avoid opioids wherever possible. And like you rightly said, multimodal analgesia, especially blocks. And if required for abdominal surgeries, even a single shot opioid subarachnoid is good for analgesia. So one thing I would tell the viewers or whoever is tuned in or listening, please do not give dexmedetomidine to these elderly patients. They have significant hemodynamic and cardiovascular effects. So opioid-free analgesia, anesthesia is good for the elderly, especially to avoid all the problems associated with whatever we talked about in the last half hour, 1 hour. So I think you've really summed up everything well, Dr. Balaji. Good work. Thank you.
Thank you, sir.
Okay, Balaji has nicely covered the management aspect. So, good that you brought the Cochrane analysis of 2018, whether Tiva or English anesthesia is better in elderly population. So, though there is Cochrane analysis has given a marginal benefit for Tiva, our English anesthetic, but they don't recommend one is superior to the other one. That is the final say of the Cochrane analysis, which came out in 2018. Now, having said that, we are going to use English anesthetic. How much English anesthetic we should use? Balaji has already described that 10% decrease with every decade. That means sevoflurane is 1 MAC is 2.2 or 2.1. At 90 years, this is only 1.6 is 1 MAC. So keep that in mind. And the second point, what Balaji has brought and brought to our attention, as well as Gobi said about avoiding sadness. So what are the drugs you avoid in this old age people? Because the incidence of delirium. Certain drugs which increase incidence of delirium are the benzodiazepines. So these drugs should be used with caution. Like an young patient, you can use 5 to 10 milligram midazolam, but old patient, you can avoid midazolam if at all you use 1 milligram only. Because that may take the patient to delirium in the postoperative period, postoperative cognitive dysfunction. So other agents you should avoid is pethidine should not be used. Then the diphenhydramine, that group should not be used. Metoclopramide or antipsychotics like haloperidol. These are the drugs which will produce delirium in the old age. So preferably use with caution or avoid these drugs. Now, inhalation anesthetic we can use, Tiva we can use. Management strategies, Balaji has told. Now, is it time to go to discuss the cases, or somebody is going to discuss the cases?
Sir, we will wait for Dr. Hethel's presentation.
Oh, okay, okay.
And after that, we'll go for interactive discussion. Yeah, Dr. Hethel Shah.
So let's start.
Yeah, please.
I'll share my screen. Is it visible? My screen is visible?
Yes, yes.
Yeah.
Full screen.
Yeah. So, I mean, a lot of things been discussed, not much left for me to present. Almost majority of the things been discussed, but I mean, this was sort of initially thought of a debate, kind of volatile versus IV anesthesia agent between me and Dr. Balaji. But then we realized that we don't want to fight with each other, as it was mentioned in the beginning also, that you should have unanimity when we speak or when we contest at a national level. So we thought to share our views and our experiences only. So I'll share my experiences. And it's an honor and privilege for me to be part of this crisp session, especially because my teacher, Dr. Thomas Kosi, who is one of the most practical person which I have met in my entire career, and he gives a lot of finest calculation, as you could have seen in his discussion also, that he is very, very meticulous and very calculative in giving anesthesia as well and teaching as well. So it is an honor, and obviously Dr. Gopinath, who is like fatherly figure of cardiac anesthesia. So let me start with what I've learned till now, and probably it's a conclusion slide to begin with. I reverse my order. The choice of anesthesia techniques would be based on multiple things. One is, most importantly, is the patient factor. So what is the overall health of the patient? What is the medical condition of the patient? What comorbidities the patient would have? You should always take into consideration the surgical factor, which is like the nature of surgery, what kind of surgery is to be done, and also about the expertise of the surgical team. So you may have an excellent surgeon who does work with good finesse, or you may have an opposite end where your surgical team is not very good and they would have a lengthy time or maybe having a lot of mass during surgery. So all these points also needs to be considered when you choose your anesthesia plan. And obviously your factor, like anesthesia factor, what kind of expertise you have, what kind of resources you have, and obviously what site where you are working, what setup, what is the facilities available, how this good setup is good, and what kind of backup you have. So all this needs to be considered when you choose any plan of anesthesia. So who are geriatrics, which we have not discussed, so I'll take up. People at this is what normal the people ages, but nowadays we may find this kind of faces at the age of 25, and we may find this kind of faces at the age of 80 also. So geriatrics means chronological age of 65 and more, which has been described by most of the countries, and they have been divided into elderly, which is between age of 65 to 74, aged between 75 to 84, and very old between age of 85 and more. Why it is important, I'll come back to those points. But what is most important is old age is not a disease, right? It's just the aging process which is happening. And why we are discussing this topic today? What is the scenario? It is a rapid growingly population in India. around 15% people are of more than 65 years of age because of increasing life expectancy. Almost half of hospital care days are being taken care by them. 25 to 35% of the surgeries which we do across India is on this age group, and mortality rates are significantly going up as the age increases. So it starts from 3% in 80 to 84 years of age to 10% in more than 90 years of age. So that's why it's very, very important, especially in a medical legal era, where we had yesterday a very good discussion by ISA only, that in this era of medical legality, we have to be very, very cautious and very, very be chooseful about what anesthesia which we are giving. And this is a Limca book record of holder of Mr. Bhatt at 93 years of age. He has undergone total knee replacement. And when I discussed this in one of the groups of anesthesia across where people across India are there, Dr. Gurunath and team has recently, last Saturday itself, they have operated on a 96-year-old patient for TCAR successfully, right? So what I'm trying to say is that Indian scenario, I'm not talking about the foreign or Western scenario. The Indian scenario is also changing, and we are definitely getting this kind of older, fragile patients for various surgical procedures. And as we know, the age-related physiological changes which happens, especially in autonomic functions, which makes them prone for hemodynamic disturbances. And there are definitely a cellular homeostasis like temperature, endocrinal changes, which is happening to this patient. And obviously with the age, there is a reduction in organic mass of all organs, and hence the organic functional reserve also. So what been discussed, the cardiovascular changes, like they would have a left ventricular hypertrophy, diastolic dysfunction, all this put them very, very sensitive for labile blood pressure perioperatively, and then you really need to titrate them with the fluid and vasopressors. The systolic reserve capacity decreases. There's definitely valvular degeneration. So these patients' valve would be leaky, or it could be stenotic. Most common would be the aortic valve, which will have some amount of sclerotic obstruction, and then those patients do pose a very good challenge, and they don't tolerate much of the hypotension. So it has been discussed, previous speaker, Dr. Balaji and Dr. Singh both have said that the cardiac output decreases 1% per year after 30 years. So, and hypotension and bradycardia are very common perioperatively. Respiratory changes, why you need to understand, because there is an increased stiffness of the chest wall, which happens with these patients. So opioids use should be reduced. There will be a reduced mucociliary clearance, and there will be a reduced alveolar mass. And all this will prone into the VQ mismatch, and that will be big challenge for anesthetic using inhalation anesthetic agents into the things. Right, and there will be definitely less uptake of inhalation agents into these patients, as been described by Dr. Balaji in previous lecture as well. Definitely there will be a reduced GFR and interference with the excretion of anesthesia drugs. So the dose which we are giving needs to be modified according to the GFR. Right. So when you take up this patient for surgery, you evaluate the pre-existing comorbidities, you evaluate the nutritional and mental status, and you assess the functional reserve of organ system, and then you make a plan of your anesthesia. I would share my experience, recent experience of 2 cases, and that would make more live and more practical. The first case, this was a 68-year-old male patient posted for CABG. This was just after induction hemodynamics, where it looks pretty stable. And we thought of doing maintenance as we usually do it with inhalational agents, and we added sevoflurane into the kitty, and we try to maintain that patient on a maintenance phase on sevoflurane. And what we found is there was a drop in pressures which was started, and along with that there was some STT changes which has happened. Now, what is our reflex mechanism when we see this kind of scenario? Where there is a drop in blood pressure which is happening, what we normally do is we push fluids judiciously if you have a CVP, which is not a very good marker, but as sir said, very dynamic parameters like PPV, SPV, which is now available with very basic monitors as well. We might thinking of adding a vasopressor, and we usually reduce or stop sevoflurane. I hope all of us are doing the same therapy when we see a hypotension happening, right? And we know that the inhaled agents does have a dose-related decrease in arterial blood pressure, right? And this is the graph which is showing that. And this effect we use normally for hypotensive anesthesia as well in our routine day-to-day practices. But the dose-dependent decrease in the blood pressure happens. It's because of decrease in a systemic vascular resistance. So there is a lowering of regional and systemic vascular resistance, which happens with increasing of the MAC of this inhaled anesthetic agents. So you have to be very cautious when you use inhaled anesthetic agents, especially in elderly patients where their organ reserves are less. They would definitely will have some amount of exaggerated response of hemodynamics, especially when using inhaled anesthetic agents. And there was a study which was showing that comparison of hemodynamic effects of sevoflurane anesthesia, induction and maintenance versus Tiva in coronary artery bypass surgery. And what they found out, though it's only 30 patient study, but what they found out is there is a more patient in sevoflurane group presented with bradycardia, and during maintenance of anesthesia, treatment of hypertension was more frequent in Tiva group as compared to the sevoflurane group. So what inference we can get is that the using of Tiva or probably IV anesthetic agents would have a less amount of hypotension as compared to the inhalational agents when we use inhalation agents. So Tiva stands for total intravenous anesthesia, is a suitable technique for elderly patient. Why so? Because as we know, and has been discussed, there is a reduced metabolism which happens with these patients, and Tiva allows a precise control over the dosage of anesthetics. If you have a TCI pumps, it is fantastic to have, but most of the centers would not have a TCI pumps. But that's why the better titration of the drugs which happens with the IV anesthetic agents. And inhalation can also be titrated, but that needs an anesthesia gas monitoring. So what Dr. Koshi sir said, that when you want to give a MAC, you have to give little less MAC to these patients, but then you need to have a AGM to understand, especially when somebody is using low flow, somebody is using maybe the metabolic flow, somebody using the normal flows. So on all that, probably the dial concentration varies, and you should have a AGM, which is again a very not available at every center as of now, right? And Tiva also helps in maintaining the hemodynamic stability, especially in elderly patients, as compared to inhalation agents. There is a precise control and accurate titration of anesthetic agents you can do to adjust the depth of anesthesia, because that is also very, very important, that when the hypotension happens and if you switch off the inhalational agents, then what happens to the awareness? So this accurate titration you can very well achieve with the IV anesthetic agents, and it allows, the Tiva allows in a rapid, smooth emergence of these patients, which is very, very important because of maybe because of age-related factor, maybe the electrolyte imbalance and comorbidities. These patients would have definitely delayed outcome, and then that would probably increase the morbidity or increase the hospital length. So that also is very, very important point to have a smoother emergence and rapid recovery. Again, the literature review, a study compared the recovery profile of elderly patients undergoing hip surgery, Tiva versus sevoflurane. What they found out that IV anesthesia group had a faster emergence and recovery time compared to inhalation anesthesia group. So again, IV anesthesia scores a little plus in compared to the inhalation agents. The quality of recovery of patients who underwent curative pancreatectomy, they have compared Tiva versus inhalation agents with QOR. This is a recovery 40 recovery questionnaire, and what they found out is that Tiva can be recommended even in patients with a complex and invasive surgery to produce a better quality of recovery, especially in a lengthy surgeries also, because more the duration of the surgery, more the drugs, and there is a chance of delayed recovery in this patient. Coming to the case 2, which has happened very recently to us. This was PAC was done on 30th June. This patient is a 66-year-old male, posted for craniotomy and brain tumor excision. No comorbidities to this patient, had a THR few months back in our hospital itself, and fairly okay blood investigations as well. Now, next day on 1st of July, we operated this patient, started this case around 12:30 with midazolam, fortwin, and propofol as an induction agent. And we try to maintain this patient on oxygen, air, and sevoflurane, which is about 2 to 3% of the concentration of dial set concentration, and MAC of about 0.7 to 0.8. And fairly, he behaved very well throughout. Hemodynamics were fairly okay. The surgery lasted for almost 3.5 hours, and after 3.5 hours, we could able to extubate this patient because surgeon has put VP shunt along with excision of the tumor, and patient did very well. What happened in post-operatively? Patient had a psychosis and deleterious state, needed prolonged ICU stay. We did CT scan in electrolytes to rule out other causes, and CT scan was showing there was no significant changes. And if you can see this ICU investigation sheet on 3rd and 4th of July, the electrolytes were normal, creatinine is also okay, and fairly good hemoglobin also. So we don't understand why this patient had because there was no surgical factor, there was no metabolic factor, which put this patient in a deleterious phase. And he recovered, I mean, in 3 to 4 days, and he has been planned to discharge tomorrow also. So when we saw the literature also, there is a comparative effect of propofol and sevoflurane on chronic post-surgical pain and cognitive functions after cardiac surgery. What they found out is that propofol produces significantly greater improvement in post-surgical pain and cognitive functions than sevoflurane after cardiac surgery. Effects of inhalation and propofol anesthesia in post-operative cognitive dysfunction in elderly non-cardiac surgical patient. This is a systematic review and meta-analysis. And what they found out that there is a moderate evidence shows that there is in elderly non-cardiac surgical patients, propofol anesthesia is superior to inhalation anesthesia for attenuating of early POCD incidences. Literature, again, post-operative cognitive dysfunction in elderly patients undergoing major abdominal surgery with either inhalation anesthesia or IV anesthesia. There was a less evidence of cognitive dysfunction in IV anesthesia group. Again, an article which says that total intravenous anesthesia with propofol associated with lower rate of post-operative delirium in comparison with sevoflurane anesthesia in elderly patient. What they found out that the propofol anesthesia had a faster emergence time than sevoflurane anesthesia. Propofol anesthesia was having a fewer unpleasant side effect, and propofol had a long-term neuroprotective effect as well. So in conclusion, they said that the anesthesia with propofol is preferable over sevoflurane. One of the interesting article why these inhalation anesthetic agents has a most common associated with the delirious or POCD state is association of apolipoprotein E4 and postoperative cognitive dysfunction. And what they found out that the inhalational agents, when you use inhalation agents as a maintenance, this apolipoprotein E4 level goes up very high in patients as compared to the IV agents. So that's the reason why inhalation agents would have a more amount of postoperative cognitive dysfunction in terms of delirious state in these patients, right? Again, there is a possibility of acute kidney injury after major abdominal surgery if you use total IV anesthesia versus inhalation. So what they found out, almost 3,660 patients in 2020 study, incidence of post-operative AKI after major abdominal surgery definitely differed significantly according to the anesthetic used, and patient receiving inhalation anesthesia may have a greater risk of post-operative AKI than those undergoing Tiva in elderly population. So that also needs to be taken into the consideration. Obviously, regional anesthesia, as Dr. Gopinath has said, it adds to lot of safety. But there are certain disadvantages of regional anesthesia, because there will be especially in elderly, because there is a difficulty in controlling the level. There would be increased sensitivity of local anesthetist. There is a limited power of adaptation of vasomotor changes, so there will be wide fluctuations in hemodynamics which can happen. It could be a difficulty in technique due to calcified ligament and gynosis of joints, and there is an increased incidence of persistent neurological problem in these patients post-operatively, right? So general anesthesia, we commonly prefer to use propofol or intermediate. Opioids needs to be very much titrated in this kind of patients. Graded induction has been discussed previously also, because the peak effect is delayed, the cardiac output is less. So definitely this takes arm brain circulation time takes a little longer, so that you need to give a very slow. The drugs to be calculated according to the lean body weight. Slower onset is expected and dose titration is needed. If you want to use neuromuscular blocking agents, you use short or intermediate acting agents. There will be twofold prolongation in onset of this neuromuscular blocking agents. Personally, I prefer cisatriptan because of organ-independent metabolism. If vecuronium you need to use, you reduce the dose to almost 30%. Try to avoid scoline, because there is a decreased level of plasma cholinesterase in these patients. So I would say definitely there is an advantage of Tiva in elderly as compared to inhalation agents, because of the cognitive function is much better after Tiva than as compared to inhalation agents, which we have recently experienced also. The circulatory complications and wider fluctuations in hemodynamics are more with inhalation agents as compared to IV agents, and the psychomotor performance is very less after use of Tiva in this patient. So I would prefer to use Tiva as a maintenance in this kind of patient as compared to inhalation. Thank you very much.
Thank you, Ethel. There's a very comprehensive coverage of managing an aged patient, and you give some examples also.
Thank you, sir.
And your vote is on Tiva over inhalation anesthetic. And you said that regional anesthesia is to be used whenever it is possible.
Yeah.
So these are your recommendations. Am I right?
Yes, sir.
Okay.
But regional will also have some challenges, so that also needs to be kept in mind.
Okay. Okay. Now, what is the next?
Yeah, we can take the question answers.
Yeah,
Yes.
please.
Yeah.
Yes. Sujata,
I wanted to make one comment about Hital. Is it allowed?
yes, sir.
Hello.
Please
Yes,
go
yes,
ahead.
Dr. Balaji.
I respect Dr. Hital Shah, but he has brought all those old studies to prove his point that intravenous anesthesia is better. He has shown studies of 2003, 2012, and just it is not debate, but still I think our approach should be balanced anesthesia rather than promoting Tiva. And what I feel is inhalational anesthetists are equally good, means rather you didn't mention about the complications of Tiva. You have shown us the advantages, all the advantages of Tiva, but what are the complications of using Tiva?
So let me take you 2-3 things. So that's why I started with the conclusion slide first. So you should be very selective depending on the factors which you are going through, as a patient factor, your setup factor, your own factors, and all this will decide your plan of anesthesia, right? Important thing is inhalation agents. I'm not saying that we cannot use inhalation agents, but you need to have a MAC monitoring, anesthesia gas monitoring, and which is very practically, if you look at, is not available at all the setups. ETCO2 is now coming up in certain setups, but getting the AGM monitoring is also is very tough. So titrating those agents is very important. The definitely there are old studies, but there are recent studies of 2021 also, and which has been coming up with more data, which is showing that the post-operative neurological disturbances, delirium and PCOD issues are more common with inhalation agents, and more research is actually going on that area, and that is actually increasing a lot of morbidity in this kind of patients. There are two things which is very important. One, in inhalation agents, the advantage is ischemic preconditioning and better myocardial protection, which probably the propofol doesn't score much over SIBO or even for that matter desflurane also. But the problem with that is that if your hemodynamics are not maintained, then what is the fun? Because if the coronary perfusion is not happening, let's say in my case, which was happening, that when I started sevoflurane, it was almost just MAC of 0.7, 0.6, end tidal of 1.02, right? At back of 0.6, 0.7. With that, if I have a significant hypotension and if my STs are showing, so then there is no point in having those ischemic preconditioning advantage in my favor. Cognitive dysfunction definitely would be having because of the elderly population, not only because of inhalation agents, but you should have a MAC value, which is difficult to have in this setup. And titration of the dosage is very easier with IV agents. And if you have a TCI pump, it's an absolute good way of managing this elderly population without having much of awareness, because awareness will also include add on to the deleterious states post-operatively. So all these points which favors more in terms of IV maintenance and less of inhalation, right? But yes, I mean, balancing act, anesthesia is a balancing act, and we should have a very tight titration of these drugs. Whatever we choose, we should have that tight titration. That's more important.
But as far as your second case is concerned, you are unfortunately blaming it to Tiva, but what induction agent or inhalational agent? But what induction agents you used? Secondly, there is hypotension is so much common in perioperative period in cardiac surgery. You cannot solely blame it through the inhalational agent, what I feel, firstly. Secondly, there are on screen also there was ST elevation. Yep. It may be due to hypotension, or it itself can cause hypotension. So what I mean to say is that, and personally also I wanted to ask you, do you use Tiva for maintenance of CFG routinely?
Yeah. So what I do is I use a mixture of that. And this, I mean, coming to the first question, the second case was a neurosurgery case. So we initially thought when the patient was having a post-operative troublesome period, we thought that there was some issue with the surgical issues. So that's why we got our CT scan done. We could not find any abnormality in CT scan. So we thought probably electrolyte imbalance, and that's why we got an electrolyte imbalance. So after excluding all the points, we thought probably this is the inhalation agents, because it was not maintained. We gave only propofol as an induction agent to that patient. We maintained the entire case on oxygen, air, and sevoflurane. So by excluding all the parameters, it's a diagnosis of exclusion. So that's why we thought of that it should not be done solely on inhalation agents. Coming to the second question, what I do in my maintenance in my cardiac surgery patient, I usually give them the propofol infusion continuously. The simplest reason is that I want to avoid awareness in these patients. And as you said rightly, there is a lot of fluctuation in hemodynamics which happens because of cardiac surgery, because of heart manipulation, because of intraoperative coronary events. A lot of things happens in these patients. So, and the commonest thing when I do the case or any of my colleagues is doing the case is to switch off. When the hypotension happens, you switch off or reduce the dose of inhalation agents. And especially when you're doing a low flow anesthesia, you reduce it, your MAC value will go down. And then when you want to really when the hemodynamics improves and you want to go up, you have to really titrate it very nicely. So that will bring a lot of changes of a lot of chances of awareness in this kind of patients. So I always run a low dose of roughly about 1 milligram per kg per hour of propofol infusion to all my patients.
I'll make a comment on that. The people who use Tiva find it very comfortable, but I am not a Tiva person. Secondly, your monitor showed not a significant elevation, but it is a lead 3 showed 8.8, and the mean pressure was 57 only. So
yeah.
Whether it is propofol or it's Tiva, that pressure you can have some ST changes. So it is not significant, but the practice of changing English anesthetic is not advisable. I manage a lot of CBG, valve, op cap, on pump. You start with 1 Mac and end with 1 Mac. It is not touch.
Yeah, absolutely. But then it is not possible. Sometimes
So
it is not possible.
It's not touch. It's
yeah.
steady. It's kept steady at
Yes.
1 Mac.
Ideally, yes, because then in low flow, then only you can achieve the standard level, right? But if you juggle with your dial concentration, you cannot have the steady state of anesthesia. And it is sometimes difficult that if you are not there in the theater, probably your colleague is managing, you would have a different thing. And that's what I said. Ki once you change the dial concentration, achieving that steady state will take a lot of time. And that is the time where you have probably chance of awareness.
So people are practicing Tiva, they should be excelling in that. People are practicing inhaled anesthetic, they are also good in that. I mean, the ischemic precondition and all not clinically significant.
Vashi sir, I just want to add one thing here. We are using the inhalational agents for a long time with the evolution of the newer inhalational agents. And the best part is we have got direct measurement of the MAC values or the BIS value. So many things are there where we can really measure the amount of inhalation anesthetics in our bloodstream and the interface of the pulmonary tissue and the blood. But considering on this other side, Tiva has got many advantages, but you cannot measure the real amount of the anesthetic agent getting dissolved in the blood, being carried to the peripheries, being carried to the end organs. It's very difficult to measure the amount of the drug, the plasma levels, the peaks and troughs, the crests and troughs. And it's very difficult. You have to titrate it very slowly and on individual to individual basis, because a geriatric patient, whatever you label, maybe 60 years or 65 years to whatever the things of 100 years also, with every age, it's not a decade. I think with every year adding on to your age, the variability in your dynamics, circulation, the pharmacodynamics, the pharmacokinetics of drugs in that particular age group, it varies a lot. So variation is a sense, it's the individual approach, the experience you have got in managing such patients, whether it's a Tiva or it's a inhalational, but it's the individual anesthetic approach that is more important, the clinical vigil, all the years around. I may read the books, I can give anesthesia based on the books, but whatever the experience has taught you, that is not mentioned anywhere in the textbooks. People are doing CABG with the Tiva, people are doing with the inhalation anesthetic agents, everybody is successful. But I think the reason, the secret behind the success is their vigil, their experience, everything being put into the practical usage. That is what I want to say here on this good discussion between Dr. Balaji and Dr. Hital. And Dr. Hital, one more point. I just want to show you, search the PubMed for all the geriatric patients. You book a Limca book of records. Did you search the entire PubMed?
Which PubMed?
Entire PubMed.
Yeah.
The 93-year-old was the highest, there's a maximum age for which the TCAR was done.
Yes.
I will just show you the screen here. You did go through that. It was published 13 years earlier, not the TKR, but the hip replacement.
Okay.
See,
some replacement surgery was done under regional anesthesia.
So 120-year-old patient, she underwent this one, THR. Okay. And thus her son was 95-year-old. I mentioned in that article. See, it was published 13 years back, but I think I should have also made some efforts to put into the Limca book of records.
Yeah. So when I put this in one of the group, lot of people have come up. They have done about 120, 103 years of old, 100 years of old. Lot of people in India have done around 100 years of patients. But yes, as you said rightly, they would have not done any effort to put it in a Limca group of records. So
It's on the PubMed. Actually, I've searched that time also. 100 plus patients were almost, I think, in the 2010 I'm talking about, there were 3 or 4 patients who had undergone orthopedic surgery who for above 100 years.
Yes.
So I didn't make an effort to put into the Limca book of records at that time. I was not aware of this book records also. So anyway, that's what.
So this was to sensitize the people that if you are doing, please try to put it. And the only perspective of my putting this case was not to demean, but it was showing that this kind of things are nowadays happening in India. Typically, we were looking at a Western data, Western things. We have never looked at our Indian things. So now a lot of things, Indian data and Indian subset people and studies and research are coming up. So we have to now look at our Indian perspective, because eventually we are looking at managing the Indian patients. So we have to have our findings with us.
Actually, even that time also, I was looking at the Western data to get that patient done for the operative procedure, because every setup is different, the resource limitations, as well as that different, what you call, age groups and the people's expectation from anesthesia and surgery. 120-year-old lying on the bed, quality of life is compromised. So at least it's a hormonal changes also at that time. And you involve all the branches. If you belong geriatrics, if you involve the obstetrics, you will come out so many good conclusions about the overall physiology of such patient. That is where I told in the beginning that the collaboration should be between the different specialties to come out winner on this front, where we can really take care better of the patients, rather than just for our glory, we're putting it in PubMed or in the, the Limca book of records. So that is the whole idea. I request now our academic coordinators, Dr. Sujata Jine and Neero Sani, to take over the questions. Many people have raised hands. So you coordinate from here on, please.
Yeah, yes, sir. Thank you very much. One of the question in the chat box, can I take?
I think Dr. Sujata, somebody has raised hand. Dr. Parna, Dr. Rajesh Tasani.
Yeah, Dr. Parna has raised her hand.
Dr. Parna, you can unmute yourself. Unmute.
Yeah. Yes, sir. Excellent presentations. And sir, in your study, you mentioned about AKI, which is more common compared to inhalational anesthesia, compared to Tiva. So I would like to know what inhalational agents were used in that, because now we also say that sevoflurane is, the renal toxicity is not an issue. So I really would like to know if AKI is more common with inhalation.
So there was one study which I could found that where they compared Tiva versus inhalation agents, and inhalation agents which were studied in that study was desflurane, isoflurane, and sevoflurane. Obviously, it was not related to compound A, maybe because of the hemodynamic parameters, and these patients, elderly patients, would have as I mentioned in my renal slide also, that they have a less reserve. And this hemodynamic changes would probably put them into AKI. They would have not required a dialysis or renal replacement therapy for this patient, but their creatinine would have jumped. They would have struggled for some time. So they've compared that propofol versus Sevo and DES, and they found out that the chances of AKI is more with inhalational agents as compared to IV. And probably it is reflected to the hemodynamics, perioperative hemodynamics, rather than obviously compound A is no more in existence. Definitely not.
Yes. Okay. Thank you, sir. Sir, can I ask one question to Dr. Balaji?
Yes, madam.
Yes. Sir, excellent presentation. And today I came across a very practical difficulty. I was in dilemma what to do. I was doing a brainstem tumor. Neuromonitoring was being done. And there was a lot of difference between my BIS, which I was measuring, and the neurophysiologist. She was monitoring, or she was also monitoring the BIS. So like there was a difference of 20, the difference was 20. So like my value, I was getting around 57, 58. So I was using more of propofol. and she was getting BIS of around 29-30. So at that point, I really didn't know like how much to give, and the patient was in lateral position, neuromonitoring was going on. But this was a very genuine difficulty which I faced today. So since we discussed about BIS, I thought I'll ask you.
Yeah, if they both are from probably from different companies, BIS
Yes.
monitoring, and secondly, calibration may be the problem. This can happen, madam, if two different company people are giving BIS monitoring system.
So basically,
So,
I
but
feel
normally
that,
this,
Parana,
yes, ma'am.
basically, I feel that there was a problem of calibration, in fact,
Yes, calibration
rather
may be
than
the
the
problem.
company, because that difference will not be that significant. A difference of 20 is a very
Yes,
significant difference. So it must be a
exactly.
problem with calibration, either yours or hers.
Yes, I do agree with this.
Dr. Panna, regarding your
Yes,
question about the acute kidney injury in the geriatric patients, there was
yes,
one
sir.
study I did with Americans, basically. I will just show
Mhm.
you. I will develop on that also. See, this was a study which was done, I think, almost around 8-9 years back. Here, actually, we had a predictors of acute kidney injury, not just the type of anesthesia. Many patients were on different drugs. Many patients were having some comorbidities also. So there are
Yes,
multiple
sir.
factors which decides about
Mm.
the acute kidney injury, and not just the type of anesthesia only, either inhalation or a Tiva. So that's what I wanted to say. So we cannot blame just the technique of anesthesia, which is responsible for the acute kidney injury, rather the hypotension. Hypotension is a triggering factor for such type of episodes. And that also depends upon the many factors, the comorbidities as well as the drug intakes of these patients.
Yes, sir. Absolutely right. In fact, I wanted to say this, but and also the fluid management also. So
No,
sometimes if you give less, yes,
perioperatively, many factors,
yes,
not just type
yes,
of
yes,
anesthesia.
And
yes, sir.
even we are using all this inhalational agent in end-stage kidney disease patient, kidney transplant patient without any, without much problem. What I feel, inhalational agent are not that much harmful to the kidney, but what sir rightly told, episode of hypotension and other factors are very important.
There are some
Yes,
56
sir.
ads.
Sir, can I say I am Dr. Shobha Vatkar from Maimar Medical College, Talegaon, Dabhade. Here I have done 110 years old patient, fracture neck femur, under femoral and LFCN, along with 1.2 ml of 0.5% bupivacaine in a spinal, and I put epidural as an analgesic. And he being a farmer from Mawad area, Pune, he was absolutely, there were no comorbidities, but I was worried about the hypertension, but by touch wood, nothing happened, sir, and he came out well. This is there in the Facebook, this is on my Facebook, Maimar Medical College Orthopedic Department. But
Madam,
then I failed to, I failed to publish. Like,
Madam, you send it to the newsletter, ISA newsletter you can send, rather than putting on the Facebook, it will become more academically published.
okay, okay, sir, I'll do that. Yeah.
Thank
Yeah.
you. Dr. Rajesh sir is raising hands
Yes,
in slot. Can we have the
yes,
question from Dr. Rajesh?
yes, madam. Thanks, madam. Madam, regarding that one first case, which was told that the patient was posted for laparoscopic bilateral hernia, he was around more than 90 years old and ISD patient with on ecospirin. So in that case, should we ask the surgeon to do the case like open surgery, and whether they need to stop ecospirin?
Were these hypothetical cases, or were they really cases that were done?
No, sir,
No,
these are the real
they
cases.
told us.
No, this is not an hypothetical case. Let me clear one thing. We have done this case in a couple of months back under ozone anesthesia group. We were 2 members dealing with the case. So this is absolutely not hypothetical. So basically, I would like to ask the same question to our speakers. How would they manage such a patient with a comorbidity, and whether they will allow the surgeon to go for laparoscopy, and if yes, laparoscopy, then how to overcome the stress response, cardiovascular stress response in such cases.
Laparoscopic surgery, I think, would be advisable at this age, because bilateral hernia was to be done. Again, the surgical expertise is very important in these matters. You can't have somebody playing around ITAP, ETAP for 3 to 4 hours, you see. And of course, elderly with so many comorbids, with intraabdominal pressure raised. I mean, IAP might not be raised with ETAP, but extraperitoneal approach. But again, these are problems that, ideally, if a surgical exercise is limited, then yes, lap would give them a better perioperative sort of period than open surgery. Because everybody understands that it's a, fine-tuning balance that you have to provide, but yes, quicker recovery with laparoscopic surgery, definitely.
Nowadays, sir, with the advancement of all drugs, anesthesia workstation and monitoring system, you can give a controlled GA and first optimize the patient, give control GA, and fortunately in hernia cases, intra-abdominal pressure is not very high. So you can very well control the hemodynamics and manage these cases. And I think Sujata has managed very successfully.
So ideally, the question would be that laparoscopy would be preferable in the elderly.
Yeah, and how to prevent the stress response of pneumoperitoneum in elderly patient?
Basically, if it is an intra-abdominal, intraperitoneal, what we prefer to do, we have done about 800 cases till now. We instill about 50 ml of 0.5%, 0.375% of bupivacaine with dexamethasone intraperitoneally as soon as they put a Verase or as soon as they put in their first port. It's given us very good intraoperative and perioperative hemodynamic as well as pain relief. So it's become standard now for us to put intraperitoneal local anesthetic instillation prior to starting the procedure. Very rarely fluctuation, and we tell the surgical colleague to keep the IAP about 10, not go beyond that. Obviously, with technology advancing, I mean, we haven't talked about robotic surgery in the elderly, but yes, there would be some point of time with. The problem again is that we seem to be reluctant to invest or ask for investment in anesthetic equipment in form of whatever we have talked about. TCI not available, AGM not available. So I think when surgical colleagues invest crores for their equipment, this would be a definite good investment for our anesthetic purposes. But again, I think that's a point for debating at a much larger platform than what we are doing now. This is clinical management. So yes, the first case would, I'm sure GA would be our choice for that, obviously. We have had a lot of discussion recently about isobaric, I mean, at least on some WhatsApp platforms for isobaric, local anesthetics and segmental spinals for all these surgeries. I do not have much experience. Can anybody throw any light on that? Because it seems to be a reasonable sort of option in terms of having restricted or limited spread and good, reasonably stable hemodynamics. I don't know. I haven't had any experience. So that was something at the back of my mind for these elderly patients who can be sort of subjected to a regional anesthetic technique with, very clear defined dermatomal blockade.
Yeah, sir. There was a discussion in the previous clip and other parts also on the platform. From the conclusion, sir, from there, what we can say is the parameters noted, the monitoring being done is not that much clear, which will give you the clear indication. Definitely the blocks came out a winner on that front with the ultrasound coming into play. But what we think at this juncture, if you really want to come out with a good physiological action, how the anesthesia really acts inside, the microcirculation monitors are there, which are being used by the Western societies. They're easily available here, which are very difficult to obtain in our setups. Very few institutions have got it. Because if you go to all the journals of anesthesia, analgesia, anesthesiology, you will see the amount of the technology being put in the research is much, much beyond which we Indians can think of doing such studies in our setups. So we are definitely paralyzed by the availability of our resources, because those type of monitors which we really require to gauge the real effects of anesthesia in a geriatric, or for that matter in any type of case, we still have to struggle to get those things because of the lack of resources. I think the few institutions which are having those resources, they should come up with those studies. But the idea was, sir, we're right here, that the winner was the regional blocks, especially under the guidance of ultrasound.
I do understand. I do understand because again, the geriatric population is growing, and these patients present at every level from district hospital upwards to a large, well-equipped corporate hospital. So I think anesthetic management should be properly focused on, because whether it's an inhaled anesthetic technique, whether you call it VIMA, volatile induction maintenance, or Tiva, or balanced general anesthesia, practically the crux of the issue is maintaining organ perfusion, which is what causes all our organ related outcomes, whether it's from top to bottom, POCD, MACE, AKI, whatever. So I think it's quite an eye opener that everybody needs to focus on maintaining proper optimization and hemodynamic control, or stability intraoperatively. At the end of the day, this is the most vulnerable population, I guess. And like I was mentioning some time back, I was supposed to have a couple of gallstones, and first thing the surgeon said was, sir, before you develop some comorbidity, surgery karwa lijega before you have before you become prone for problems. So in those terms, I said, it is, as you age, you are adding further risks to the whole entire medical fraternity in managing you, whether it is anesthesia, surgeons, nursing staff in the post-op. So prevention obviously is the best thing. And having done so many years of cardiac anesthesia, I would like to again reiterate what Thomas said, Dr. Koshi said, that we've always depended a lot on our inhaled anesthetics for perioperative care of patients. Tiva, yes, you can, but obviously a cardiac setup has much more managed, or the equipment in terms of either neurological function monitoring or whatever, BIS, NIRS, TCD, or even cardiac output monitoring. So I think we have been privileged to use those to manage our patients well. But currently, again, with the elderly, the TAVIs and percutaneous and stuff like that, you'll have much more problems on your lap. I think it was a very interesting evening. Thank you, Dr. Bajwa.
Sir, we are privileged to have you and Koshi sir here, because this is something, the decision has to be given, the solutions have to be sorted out for these type of controversies. I request Dr. Sujata Jain and Dr. Neeru to take over the people who have raised hands, and to at least get questions from them.
Dr. Shashi Patil has raised hand. Dr.
Rajesh Tosani is there for a quite long time. Dr. Rajesh Tosani.
Yes, good evening, everyone. It's a nice presentation by Dr. Balaji and Hetal. I want to add one comment that most of the time our book has mentioned that cardiac output is depend upon the heart rate, contractility, preload and afterload. But recently, one literature has shown that the valvular function is very important. So pre-op assessment is very important. And if you find any hypotension intraoperatively, it's better to diagnose, because most of the anesthetic agent are the vasodilator, and the patient is having a normovolemic hypotension. So in such kind of patient, if you go with the Trendelenburg position, and if you are improving in your hemodynamics, means the patient is hypovolemic or low SVR. And if patient is not improving, it may be a cardiogenic shock. So you have to treat with the vasopressor or with the inoconstrictor. So this is my overall experience, that your extubation criteria should be fast track, but induction should be very smooth, slow, and very safe for the patient.
Which are the risky? He mentioned about the heart rate. So I'll tell you, geriatric patient. The topic is today's geriatric and cardiovascular. Which are the risky patients we get? So one is patients with severe LV dysfunction. So let us say 30, 40, 50. Above 50 is normal, 55 is normal, but 50. Mild LV dysfunction at till 40 and severe LV dysfunction less than 30. So less than 30 is a risky patient. You should be prepared to start some support whenever. Don't delay this. So that is one. Second is patients with diastolic dysfunction. Grade 1 is okay. Everybody can manage. A little more fluid is required. Grade 2 also can manage. But grade 3 diastolic dysfunction, restrictive function. Such patients have, along with diastolic dysfunction, LV is not dilating, LV is not pulling blood from the left atrium to LV. So there is a reduction of cardiac output. So there, inodilators will be used, like inodilator like dobutamine or milrinone will be useful. And sometimes when you use milrinone, the BP will fall. So that can be combined with noradrenaline. Third risky patient is patient unable to raise the heart rate. Sometimes we get patient with a significant beta blocker and is not able to raise the heart rate, then we are in trouble. So that patients may require some amount of pacing. If they are not responding to our some dose of beta agonist not responding, then require pacing. So these are very, very rare patients. And regarding monitoring, any patient with more than 3 hours of surgery, better to go with an arterial line. Or patient with expecting fluid shift, better to go with the arterial line. Then you can liberally use your table control that the previous person has said, that Trendelenburg position. You suddenly get 250 ml of fluid into the heart and improves the heart rate. So that is other thing. So these are the thing, and most important in all geriatric patient tips, take it from me, there may be having occult heart disease. So ST segment monitoring in every case is important. Whether you are, it's a short case or long case, please monitor ST segment along with heart rate and BP. Having managed so many cases with the different dysfunctions, severe diastolic dysfunction and severe systolic dysfunction, day in and day out, these are the risky patients, but these are also interesting to manage and improves our skill. So we should be grateful to such patients. They improve our skill.
Thank you, sir. Thank you so much.
Sujata, please go with the chat box questions or ask who has raised the question.
Yes,
Sujata?
one more question in the chat box regarding this low EF. If the patient is of 30% EF posted for laparoscopic cholecystectomy, what should be the ideal induction agent? And if etomidate is not available, can we use combination of propofol and ketamine? Also, can we use choline in such type of patient for intubation?
Choline to be avoided is already told. Ethel Shaw is already said there is a problem with choline. Ketamine is again a preferred, not preferred, to be avoided because of this thing. But in ketamine indications, you want to make instability. So if the patient is having 30% ejection fraction and is not a contraindication for a propofol, etomidate is not available. I have induced so many cases of 30%. You give 2 cc like that, and along with some amount of sevoflurane, you can induce. And whenever there is hypotension, give a little bit Trendelenburg position and give frenin. That's not a problem. Our start support. So induction will be slow and it will take some more time, and the BP will stabilize. And if you want to maybe restrict the fluid, use more of inotropes for vasopressors. And very important to is 30% ejection fraction, arterial line, and a central line and ST segment monitor. 3 are mandate.
With your permission, I would like to add certain things in this course, sir. Important thing whenever you are dealing with a low ejection fraction patient for any surgeries, the most important part is not intraoperative. The most important part is a preoperative optimization. So best thing is to do a preoperative optimization of this patient and then take them into the stable condition intraoperatively. They would not trouble you much. So important thing is preoperative optimization of this patient is very important, which probably most of us I mean, in our practice don't do. So that is one thing which I would highlight again and reiterate in this forum is that see the patient preoperatively, assess the history, look at his cardiac reserves. If you feel a little dilemma, optimize them and then probably take up for the surgery. Then you would have excellent smooth course perioperatively.
I think that's a privilege in lots of places, Dr. Hetal, because obviously the surgical colleague might not be keen to wait for 2 months to optimize. So I think, yes, we all discussed right from the evening that, preoperative optimization is ideal, might not be possible all the time. So in which cases you need to, balance your anesthetic drugs, whether polypharmacy or regional or whatever, along with monitoring. So don't ever I think the focus should be on proper adequate monitoring of what you think are the problem areas. So patients with systolic dysfunction who are likely to have hypotension, it's ideal to have invasive blood pressure monitoring. I won't go for a central line for a cholecystitis, but cholecystectomy. But yes, at least an invasive. Even if you don't use it, just keep it on, switch, put in a stick in a line and keep it flushed. And, in case you require, you can urgently monitor a patient. We do this often because, right now, after leaving Nizams, I'm in a government sort of organization which caters to the lower segment of population entirely, sort of very dedicated. So these are the ones who come and, handle into our labs with hardly any medication, very poorly managed or optimized, but again, it's maybe experience or availability of all the molecules that we can currently use, which are practically on off or have good profiles, especially propofol with its context sensitive half-life for Tivas. Yes, you don't require a TCI pump for giving Tiva. You can very well use a continuous infusion device, syringe driver. I think it's up to you to tailor a good program and have all your colleagues on board about how you manage a patient who is potentially trouble sort of for you on the table. But all these patients, they are all geriatric problems. Biological reserves are so low. You need to look out for trouble. That's the problem. You need to look out for trouble.
Thank you, sir. Can I take one more question?
Yeah, please go ahead.
What is the maximum infusion of injection noradrenaline that is administered in a septicemic shock when injection vasopressin is to be introduced in such scenario of septic shock? Anyone?
Yeah, septic shock, septicemic shock. See, basically that's an entirely, it's out of context of this today's subject, I guess. But yes, we have gone up to even 0.75 to 1 mic per kg. But of course, we don't give norepinephrine alone. We always, before we switch to vasopressin, we add epinephrine. And if that also works or doesn't work, obviously, other modalities, but vasopressin, if a couple of inotropes are in place, not just with norepinephrine.
And to add to that, there are certain centers you use vasopressin instead of norepinephrine. And sometimes we use norepinephrine, being starting usual dose is 0.02 to 0.05. Go up to 0.1, and it is not responding. The diastolic BP is remaining low, 40, 45, like that. We need to diastolic BP to come up, and the mean arterial pressure of 75. Then you start vasopressin, 0.3 units per kg per hour, and you can increase. So delayed starting is always a dangerous thing. You start, the BP improves, you can discontinue, but don't hesitate to start. And one more thing is that you are putting a central line is just not for monitoring CEP alone. You want to start an inotropy, you need a central line. So that also is an indication.
Next question, please. Niru madam.
Dr. Shashi, you may unmute. Ma'am, Dr. Shashi has raised her hand for
Yeah. I think she has posted a question in chat box also.
Yes, ma'am. Her question is regarding the cardiac problems occurring in due to pneumoperitoneum in elderly patients with cardiac illnesses and comorbidities. So basically, I think she wants to discuss the cardiovascular issues developing out of the pneumoperitoneum.
Yes, one has to be very cautious when pneumoperitoneum is induced. Like I said, quite a lot of surgical colleagues would stop. I mean, if you discuss, they would accept even 6 or 8 millimeters of 6 or 8 IAP is good enough for them. But again, depends on what the axis, what if it's a some pelvic organ, then they have to give a Trendelenburg. If it's not, it's reverse Trendelenburg. If it's a cholecystectomy, so quite a lot of these would depend on the surgery, and obviously hemodynamic responses would be there. Like I said, again, intraperitoneal bupivacaine has helped us a lot, and maybe somebody could try it in their centers. But otherwise, yes, if you have a cardiac patients and if pressures are going up and tachycardia is there, then you can resort to nitroglycerin infusions in low doses, 0.125 mics per kg per hour. So that is something that you can resort to control the pressures. But apart from that, the reduction in the IAP can quickly give you control over the hemodynamic responses. So monitoring, obviously, if you have a high risk patient. So you've talked about ST trending and volume responses. So if you can get down the ETCO2 a little bit with increased respiratory rate, that also helps to counter the system sympathetic responses to the CO2 being used. So IAP is very important to modulate in these exercises with poor cardiac reserves.
So we have another question by Dr. Chandrasekhar. I think he basically wants to discuss with the introduction of sufentanil and remifentanil, with the availability of these drugs in our practice in India, will it change the scenario of hypotension in geriatric patient? Will there be some improvement?
See, remifentanil more than sufentanil is an on-off molecule. So you need to be extremely careful when you use remifentanil, because if you don't have sufficient analgesia on board before discontinuing remifentanil, if the cardiovascular or the hemodynamics will go entirely haywire. Sufenta, yes, I've used in England. I've used remifentanil in England. All of these molecules are very useful for those where you can add other modalities. So a good block in place, central neuraxial, or just a subarachnoid block, or a tab block, or a ESP block, or whatever. Any of these, depending on the surgical site, along with remifentanil introp, yes. But remifentanil to depend on that alone for hemodynamics, certainly not.
And so we are talking a lot about hypotension at the time of induction, but what we face practically is that there is 4 minutes of hypotension which we manage, and then comes the intubation time, and after ventilating for 3 to 4 minutes, and how to manage the exaggerated intubation response now in these elderly patients, because that's another time point when we encounter such hemodynamic fluctuations.
I don't know about what your practices are, but generally at least in the elderly where I have or I think there is a problem, we give propofol in sort of titrated doses and quickly give rocuronium, so that there is a very small period of less than 60 to 90 seconds of hypotension or ongoing or developing hypotension, and I have a laryngoscopic stimulus which brings up the pressure up again. So we always add lidocaine prior to intubating or doing a laryngoscopy. So that's something that has been time tested and is very helpful. Especially in the geriatric patient, I would not recommend using magnesium or a vasodilator or deepening the planes, but that should do.
So a shorter muscle relaxant which will have in early onset of action.
Exactly. You're countering the hypotension of induction agent with a quick sort of natural response to laryngoscopy.
I start sevoflurane 1 mAc along with the propofol induction. So when I am intubating, patient is already reached 1 mAc level. At least 0.8 to 1 mAc, it will be there. So along with propofol,
We all follow that. We all use induction. I mean, as a co-induction. Yes, that also. I mean, that is nearly everybody does that, I guess. Any more questions?
Yeah, there is one interesting question. The first question, in fact, Dr. Sujata, can you read the question by Dr. Ganesh Tendulkar?
Is the question he mentioned as single level discectomy in a patient with the comorbidities. Patient develops more prolonged hypotension. Surgeons are not keen to catheterize the patient. It is very tricky to use vasopressors as the patient starts oozing. If we have used ephedrine, can anybody enlighten me on a better way of management of this hypotension?
Single level discectomy, prone position, patients with problems, obviously there will be hypotension. So there have been occasions where we have told our surgical colleague this is high risk, and we have done it in lateral position.
The district spine surgery in lateral position.
Oh yes, if your surgeon is good, why not? They do it in lateral surgery. Oh, I mean, yes, we have seen all this.
When you can give anesthesia in prone position, why can't they do surgery?
Why can't?
No, please ask your surgical, whoever has asked the question, ask them to, if there is high risk patient. See where we did this initially, this is, I'm talking about 1983, 84. That is when we started realizing that yes, neurosurgical or spines at least could be done in lateral. Dr. Kak was our surgeon in PGI. He was the head of neurosurgery. So Professor Kak was adept at everything. I'm talking about 40 years ago, not now. So, and we have had a lot of, like I said, following all that experience, we have had lots of patients who have had recent cardiac surgery, sternotomies. So putting them in prone position for discectomies or spine. So they're all problems. So we have always discussed with our surgical colleagues, and it was done comfortably in lateral.
Yeah, sir, he used to do in 32 also, sector 32. He was director there also.
You were there, yes.
No, sir.
I think
when I
must
joined, he
have
just
heard.
retired 1 year earlier, but I used to listen to his surgical skills.
Absolutely, absolutely. I mean, you would be surprised. We wouldn't get, I mean, we used to get gases from, or rather not get gases from Faridabad, superior gas supply. So he would be so comfortable doing discs under spinal, epidural. So we would just give him a spinal or an epidural, and those days we didn't have catheters. It was 20 to 25 ml bolus of lidocaine, and Kaksa would patapat do his spines under epidural and single shot subarachnoid, and that was also no pipivacaine those days. Heavy lidocaine 5% point. That's it.
Yeah.
So I think it is possible. So yes. Prone and giving vasoactive drugs to improve blood pressure would cause ooze, and they would have a difficult time. But I think I would prefer them to have a difficult time rather than me having a difficult time with the patient.
Sir, I would just like to add here that if this hypotension, if it is associated with bradycardia, then a small dose of glycopyrrolate, maybe 0.3 microgram, that will be also helping to raise the blood pressure.
Very right. If there is no if it is only a rate dependent cardiac output, like Dr. Koshi also mentioned earlier, amongst the various rare scenarios, just giving them a little bit of glyco or atropine, small dose, just causing enough tachycardia to bring up that output. It's just like our high spinal.
Sir, but just one question. Sir, Koshi sir, one question here to Gopinath sir. Sir, we were told, we read also in Miller and other books that when you give atropine in a lower dose, it has got intrinsic activity which can cause bradycardia.
No, I'm not talking about low dose atropine in the sense they give 0.1 milligram. I'm talking of give him 0.6, not give him 1 or 2, 1.2 or 3.
Yeah, that's why interesting. These are interesting sometimes.
Yes. No, absolutely. I do agree. I mean, I should have probably specified when I said low dose. So for us, because low dose, generally everybody, keeps pumping 1, 2, 3 ampules inside.
Correct. That's so maybe one of the problem what I observed is you give any number of atropine or glycoprotein, the rate will just refuse to rise. That is the patient here. We are having the problem. It will stay at 48, 49, 40 like that. It will not rise a single beat. Those are the patients which create problem. If the patient is
How to manage those patients, sir, then?
Low dose isoprenaline I've used.
Yes.
Dopamine.
I tell you.
Isoprenaline helps, sir.
Absolutely.
Isoprenaline, but we don't now isoprenaline is many centers is out of this thing. So isoprenaline you can try. This atropine not responding so atropine and glycoprotein not responding, that mephentermine sometimes they respond.
But dopamine also gives a good response sometimes at these patients.
So trial and error.
Infusion.
Terbutaline, yes. I mean, so many things we have used for improving rate. I think we can keep talking for a long time.
Yeah.
One last question.
Can I ask one question?
Yeah, Dr. Shashi Patil, please.
Yeah. Because the question I had asked is not, I am not satisfied. When we are doing laparoscopic cholecystectomy in a patient who is already having IHD or maybe CABG or post-angioplasty, and if we are doing, when we are increasing the gases level, and if the patient start getting arrhythmias, should we continue or we should discontinue the surgery? Means when you get some cardiac complications after doing laparoscopic cholecystectomy, after starting the surgery, should we continue or we should discontinue that?
Depends on what dysrhythmias, madam.
There were arrhythmias. Means VPCs were coming.
No, VPCs you can manage, madam. But again, I don't think it requires to be discontinued, because if the patient has had whatever was optimized, that's why we spoke so much about optimization of patients.
Optimization, yeah.
Yes. So they will do well. So if it is some dysrhythmia, yes, we have given some amiodarone, which was not responding to lidocaine or amiodarone infusion, and continued with the surgery and finished off.
Okay.
Basically, sir,
But
that
we can
also,
continue.
Madam, also depends upon how much pressure the surgeon is using for
Yeah.
You have limit the pressure to 10 to 12. No, that will be fine. If you taking the pressure to 15, then you are compromising the venous return, and definitely the electrophysiology is disturbed and arrhythmias can occur. VPCs can be managed, but the other arrhythmia should not ensue. That you also have to see.
I said right from the beginning that IAP should be modulated. IAP of 10 to 12, 8 to 10. See, that if you have an understanding surgeon, I think it works very well.
Well, okay. But we can continue with the laparoscopic surgery.
Yes, madam. Yes.
Yes. Okay, thank you.
Even in the
point to remember is a post-angioplasty, post-ABG patient is a better patient. His coronaries are puffies.
Yeah, definitely.
If you take away those two categories, somebody with IHD with no intervention is going to be a nightmare.
The other patient is more risky. You get a patient with the post-angioplasty. Angioplasty, I think the effect lasts for 2 years, and CABG surgery 5 years. So that take it as a better patient.
Dr. Bhatta, if you don't mind, I'd like to can I leave?
Yes, sure. Over here, leaving, everybody is leaving almost. Sir,
Yes,
thank you for the words of wisdom and your benign presence is precious for us. Your sir and Koshi sir, and you have done a very good job, sir. I think we have satisfied almost all. Dr. Shashi Patil, are you satisfied now? I think that word satisfaction was used. So that
Yeah, because what the question I had asked was not answered, means according to my issue. So I asked again. Okay, thank you, sir. Thank you very much.
Thank you very much, everybody. Had a wonderful evening. Thanks. It's nice seeing you again, Thomas. Bye. Good night, everybody.
Good night, sir. Good night.
Good night, sir.
Wonderful session.
Dr. Manisha, you take over now.
Yeah. I think any more questions, Niru? No questions in the chat box now remaining, no?
No,
They will
ma'am,
never,
we
they
have
will never end. They
discussed.
will never end.
Okay, okay. Definitely, we had a very good discussion today evening in presence of the great teachers, Koshi sir, as well as the Gopinath sir, and excellent presentation by Dr. Balaji and Hetal. But then again, I would like to convey here that it was definitely not a debate, because it was your experience what was more important than the debate between the Tiva as well as the additional agents. And very good take-home messages has been given by all the faculties. Like the first I liked the most given by Dr. Gopinath sir was pre-operative optimization as well as pre-operative evaluation and assessing the hydration status of the patient. That is really important. Second thing, the point raised by most of the faculties about the role of inhalational agents in causing post-operative cognitive dysfunction. That is very important, and that we have to keep in mind all the time. Goal-directed fluid therapy, yes, of course, that will be better choice of fluid therapy for all the geriatric patients. And here again, use of opioids that needs to be restricted. Avoid dexmedetomidine in elderly patients or give titrated doses, titrated double diluted doses of propofol for induction because it can cause hypotension. And avoid all narcotics, benzodiazepines, pethidine. That was a good message given by Dr. Thomas Koshi, sir. So it was really nice discussion. Many questions were answered by all the faculties. I hand over the mic to Dr. Bajwa, sir.
No, mine is over now. It's Dr. Manoj's turn. Dr.
Yeah.
Manoj. We should finish. Dr. Manoj, you have to finish the scene.
Okay, I would like to thank ISA National for choosing me for the vote of thanks. I am very grateful to the ISA National President, Dr. M.B. Bhimeshwar sir, for his blessing, support and guidance. My sincere thanks to ISA National Vice President, Dr. Mahesh Kumar Sinha sir.
He has joined, sir. He has logged in. Dr. Mahesh sir is there.
Okay. ISA President-elect Dr. J.B. Divatia sir, ISA National Academic Committee Chairman, Dr. Venkatgiri KM sir, for their support and blessing. I am very thankful to ISA National Dynamic Secretary, Dr. Sukhvinder Jeet Singh Bajwa, for his untiring day and night effort for upliftment of ISA. My sincere thanks to immediate past Secretary, Dr. Naveen Malhotra sir, and immediate past Treasurer, Dr. Virender Sharma sir, for their support and guidance and hard work for the society. My sincere gratitude to all the members of present Governing Council of ISA National for their support and help. My sincere thanks to today ISA CRISP Series 3 Chairperson, Dr. R. Gopinath sir and Dr. Thomas Koshi sir. You have shared experiences and knowledge with us for such a difficult topic on the geriatric anesthesia, which was beneficial for the member of ISA. I am very thankful to today ISA CRISP Series 3, all the speakers, Dr. Gurikwal Singh, Dr. Balaji Asingunkar, Dr. Hetal Shah, for their excellent deliberation, which was very beneficial to our members. My sincere thanks to today academic moderator, Dr. Sujata Jin and Dr. Niru Sahni ma'am, for their excellent job for conducting today ISA CRISP Series 3. Thank you, Dr. Sujata Jin madam and Dr. Niru Sah ma'am. I express my deep sense of indebtedness to this CRISP series program head Dr. Chintala Kisan and Dr. Manisha Katikar madam for their hard work and organize this CRISP series in a very right way. My sincere thanks to all the past president of ISA and all the state and city branch office bearer and all member of ISA and all the postgraduate student of our fraternity. Thank you once again. Long live ISA.
Long live ISA.
Long live us.
Yes.
Thank you very much.
Thank
Thank
you.
you and good night to everyone.
Thank you, sir.
Good night.
Thank you.
Thank you.
Good night.
Thank you, sir. Thank you, everyone.